So we're going to have a very varied discussion here from what you don't have in the programme what the titles of the papers are, and I've just been told, so I'm really looking forward to this. So I'm hoping that you're all, we're going to have a very interesting discussion for the next hour and 5 minutes or so. So I want to first of all introduce Sally Friedman, Victoria Petitjean and Shakira Hussain. I'm going to introduce them all individually before they commence. The title for our session this afternoon is Respect and Support for Diverse Families. So we're going to go a little bit different from the order that's printed here. Sally Friedman is going to speak first. She's Vice President of Legal Advocacy at the Legal Action Centre, a non-profit law and policy organisation that fights discrimination against individuals with criminal justice histories, substance use disorders and HIV/AIDS. So she has litigated in precedent-setting cases. And what she's going to speak to us today is about the right to parent when following doctor's orders for treatment of opioid use. So Sally, over to you. Thank you.
Thank you very much. And I'm going to click in two places at once. So yes, the Legal Action Center where I work is based in New York City, and we're a nonprofit organization that provides a legal and a policy approach to expand access to treatment for substance use disorders and to avoid a punitive approach to people who have the disability of substance use disorder, as well as people with HIV and people with criminal justice histories. And I'm going to introduce an issue today that really hasn't been discussed so far this week, at least where I've been here, which is the issue, disability of substance use disorder, which is more commonly known as drug and alcohol addiction. And people often don't think of substance use disorder as a disability or even a disease. But it is a brain disorder, and under United States law, it is recognized as a disability that is afforded the protections of our anti-discrimination laws. And I've noticed as I've sat here throughout the week that many of the themes that people have talked about time and time again with respect to a host of disabilities apply equally to people with substance use disorders. And sadly, those are things like stigma and discrimination, the perception of individuals as somehow morally bankrupt and incapable of parenting. In the United States, parents, especially women, and especially women of color who have substance use disorders, are demonized by the media and really throughout society. And the response, because of this demonization, is often a punitive response instead of a health approach. And in fact, the treatment capacity is horribly inadequate in the United States for substance use disorder. There's not enough treatment, not enough providers. Many of the providers don't use evidence-based practices, and people often cannot afford treatment. And even though the rates of substance use disorder across races and ethnicities in the US are similar for all races and ethnicities, white people have greater access to treatment. And people of color are more likely not to get access to treatment and to get involved with the child welfare system, which obviously has a huge impact on family life, as well as the criminal justice system, which also tears apart families. So today, I'm going to focus on the opioid crisis and opioid use disorder because, in the United States, about 130 people die every single day from an opioid-related overdose. This is the #1 public health crisis in our country now. Since we all woke up this morning, probably 60 or 70 people have already died, if this is an average day. And in response to this crisis, public health authorities and government officials at every level of government have called on for the increased use of what's known as medication-assisted treatment, or what I sometimes and others call MAT, which is the evidence-based treatment for opioid use disorder. And what medication-assisted treatment is the use of medications combined with counseling and behavioral therapies to treat substance use disorders. And there are 3 medications that are currently approved for treatment. Methadone, which most people have heard of, buprenorphine, which goes by the brand name Suboxone, and more recently an injectable drug called naltrexone, which goes by the brand name of Vivitrol. And they're all different, they have different properties, but what essentially they do is they normalize the brain chemistry, which has been altered by misuse of opioids, especially over a prolonged period of time, and they latch on to the brain receptors and they block the euphoric effects of opioids. So if you take heroin, for example, and you're on methadone or buprenorphine, you won't get high from it. The effect is blocked. And they also relieve people's cravings so that they don't spend their day craving the next high, and that they don't also go through withdrawal. And so people who are in treatment with these medications function like everybody else. They're not high all day or at all, and they can go about their daily lives, going to work, taking care of their children, and you would not know. When someone's in recovery and being treated with these medications, you would have no idea that they suffered from this disease of opioid use disorder. And there are dozens of studies that show that, that MAT reduces illicit drug use, communicable disease transmission, overdose, deaths, and criminal behavior. And I'm not going to take the time to kind of cite them all, but they're here in case you want to. And in the child welfare context, it hasn't been studied as much, but in one study of parents that were involved in a program called the START program, where parents were given access to these medications, they found that after 1 year of receiving this treatment, parents were 120% more likely to retain custody of their children. So the evidence is overwhelming, and including for pregnant women, which many people are shocked to hear. But when women are pregnant, methadone and buprenorphine are the standard of care. In fact, it's dangerous to the fetus not to provide treatment with these medications because going through the withdrawal from heroin or prescription painkillers can cause fetal distress and miscarriage. Yet, despite this overwhelming medical and scientific evidence that these medications are the standard of care for treatment of this disability, we at the Legal Action Center get calls and emails from parents all over the United States when they are being forced off their methadone or buprenorphine by parts of our child welfare system. And judges, child welfare agencies are telling them that a lot of these parents have gotten involved with the child welfare system because of problems when they were in active addiction. And then when they go into treatment and enter recovery and are doing very well, they're told by these judges and child welfare agencies that they've got to get off the methadone or off their Suboxone, or they will not regain custody of their children. Or they're told that their dose is too high, or sometimes they're even told by a judge that they should switch from one medication to the other, even though it's against their doctor's orders. I'm going to give you some examples of how this has played out and some of the people that have called us. We got a call from Melissa from Ohio, who had given birth to a healthy little baby girl. And when Melissa got pregnant, she had been using heroin, and she went to the doctor when she found out she was pregnant. Her doctor recommended that she go on methadone to stabilize her pregnancy and prevent harm to the fetus. She did, and she did very well on the methadone throughout the pregnancy. She was not using any drugs illegally. But after she gave birth, the hospital called the child welfare authorities, as our federal law actually requires them to do, so that they could prepare what's called a plan of safe care. But sometimes what happens is that ends up triggering a child abuse and neglect report, even though it's not supposed to under law. And so she was not allowed to see her newborn, not allowed to take her baby home from the hospital. And even though it's also the standard of care for newborns who are born to mothers who are on methadone to be close physically to the mother and to even breastfeed, but she was not allowed contact. And we had to advocate for her, and eventually she was able to get access to her baby and take her baby home, but she wouldn't have otherwise. And then we also were helping a woman who contacted us from a small place in New York, outside of New York City. New York is a huge state with a lot of rural areas, and so 2 or 3 hours from New York City is a very quiet countryside. And the woman there had given up voluntarily, she'd given up custody of her 8-year-old daughter when she was in active heroin addiction. And she later enrolled in a methadone program, and after 1 year in the program, she had been completely free of illicit drug use that entire time, was doing very well in treatment. And so she went to the court to petition to have her child returned to her. She had given her child to her mother, so the grandma was taking care of the 9-year-old girl. And the judge said that he never lets parents who are on methadone or Suboxone have custody of their children unless they're off it for at least 6 months, and said heroin and methadone, that's the same thing. And she contacted us because basically she was left with no viable path. Because she knew that if she were to try and get off the methadone, it would greatly increase her chance of relapse and potentially overdosing and dying. But if she didn't get off, she wasn't going to get her child back. Sorry about that. So why does this happen? Well, for a lot of the same reasons that have been discussed all week, there's just horrible misperceptions about people with disabilities and stigma. And this happens in general with people with substance use disorders, but when people are getting treated with methadone or Suboxone, there's like a whole additional layer, because these two medications are actually opioid-based as well. And so their properties are very different from like heroin and oxycodone and prescription pain medicine, because those are short-acting opioids. So if you shoot up heroin, it goes straight to your brain, you get high like immediately, and within a few hours you start going through withdrawal and start craving again. But with methadone or Suboxone, it's a longer-term, longer-acting opioid that distributes over time, like over a whole 24-hour cycle in your system. And you, like I said earlier, you don't get high, you don't experience withdrawal, you don't experience cravings, and you can function perfectly well. But because of the similarity, because it's opioid-based, there's often this idea that you're just substituting one addiction for another. And there's like a preference by people for what we call like the 12-step methods and sometimes faith-based approaches to treating addiction and counseling, and a huge stigma against using medication. So, you know, it's kind of opposite of what I've been hearing all week. There's been sometimes skepticism about a medical model. Here, it's the medical model is the standard of care to treat this disability, and yet there's a lot of hostility to the medical model for treating addiction. But it's really no different from treating any other chronic condition like diabetes or high blood pressure, where you take a pill or some kind of medication on a daily basis for as long as you need it. Often, like I said earlier, there's a view that you're on, because people dislike the drug, if you're on what they view as a dose that's too high, you'll have a judge tell you to lower your dose. I mean, what kind of judge would ever tell people how much medication they should take? But they do it all the time with respect to this. Or they say things like, you've been on that 3 years, that's time to get off. Even though all the studies will show that forcing someone off the medication actually, again, puts them in higher risk. So the denial of access to these medications is really a disability rights and health equity issue. And people, I'm sure, are familiar with the Americans with Disabilities Act, which is the federal law in the United States that prohibits states and local governments, which includes courts, and all kinds of child welfare agencies from discriminating on the basis of disability. In the US, we have another law called the Rehabilitation Act of 1973, which prohibits discrimination by the federal government or federally funded agencies. So if a court gets federal money, they're also subject to the Rehabilitation Act. And people are often surprised to learn that people with substance use disorders are considered to be individuals with a disability, and so they are protected by these laws. The definition, I figured the lawyers in the room might be interested in how the ADA, as we call it, defines disability, which is basically that there needs to be a physical or mental impairment that substantially limits one or more major life activity. So under the regulations that implement the ADA, it says very explicitly that addiction is an impairment. So then we just need to show whether it substantially limits one or more major life activities. And the regulations give a whole list of examples of major life activities, and the ones that apply mostly to addiction are neurological functioning and the ability to care for oneself. So there have been many cases that have said that people with substance use disorders are considered individuals with a disability. unfortunately, the law does not protect people who are currently engaging in illegal drug use, but they are protected from discrimination in healthcare, which is also very common in the US. Healthcare providers who mistreat people who are current drug users. But in the case of the topic I'm talking about, medication-assisted treatment is not the illegal use of drugs, so that doesn't really even come up. So under the ADA case law, there's 3 types of discrimination. One is disparate treatment, so that would be treating someone differently because of their disability. And again, this applies to all disabilities, across the board. So if there's a policy or practice that treats people who use wheelchairs differently from people who don't, that would be disparate treatment discrimination. Disparate impact discrimination is when there's a neutral policy or practice, but it disproportionately affects people with a disability. And finally, the ADA requires government agencies to make what are called reasonable accommodations for people with disabilities. And if they don't do that, that's also a violation of the ADA. So years back, the Legal Action Center developed a legal theory that courts that prohibit the use of medications to treat opioid use disorder, or that they set the kind of arbitrary requirements that I described, can violate the ADA and the Rehabilitation Act, which is the one that applies to federally funded agencies. And under all 3 theories, we believe this is discriminatory. So we set about to litigate this issue a number of years ago and kind of put the word out that we were looking for cases, and that's when we started getting calls for people like Melissa and the other woman I described. One of the greatest challenges we found is another issue that has come up repeatedly over the week, which is lack of access to justice. So people would call us, if they have a child welfare case, they'd get assigned a lawyer, because you are entitled to a lawyer in the United States if there's an abuse and neglect case against you. But the lawyers often, I would say pretty much uniformly, either agreed with the judge that they might as well just get off the medication, and wouldn't talk to us. So we needed the cooperation of local counsel so that we could provide them with assistance and explain this kind of novel, cutting-edge legal theory to them. And we got 0 cooperation from the local attorneys. So we decided that we needed to involve the US Department of Justice Civil Rights Division, because their job is to enforce the ADA. And so we basically collected all of our stories from clients, and we contacted the attorneys who work in the Civil Rights Division, and we explained why we think this violates the ADA, and they immediately agreed with us once they understood the issues, and they hadn't been aware of them because people had not been complaining to the Department of Justice because people did not realize their rights were being violated in this fashion. So as a result, oops, did I do that too early? Oh, right. So the Department of Justice in the New York area issued a very long opinion letter explaining why these kinds of practices violate the ADA. And then the whole department nationally created an initiative to remove discriminatory barriers to medication-assisted treatment. There's also, there's other legal theories we've developed about why this violates the US constitutional due process rights, and also under state law, why this is not in the best interest of a child to prohibit a parent from taking the medication that is keeping them alive and free of illicit drug use. Parallel activity goes on in the criminal justice system in the United States on a daily basis. So we also wrote a report on why denying people access to these medications in the justice system violates the ADA. And it almost seems miraculously to me, but 2 federal courts recently issued decisions. So it's the first time a federal court has weighed in on the issue and agreed that denying access to methadone or Suboxone in a jail setting likely violates the ADA and the U.S. Constitution, one of the cases held. So just to conclude, I mentioned earlier that access to treatment is really not equitable at all in the United States, and so it's not surprising that most of the parents who contact me are white. And so the whole we've stepped back and look at, well, why are Black and brown parents in the U.S. not even getting access to treatment in the first place? And so that is a huge part of the problem that we have to address along with us. And I'm going to end because I think my time's up.
Thanks very much, Sally. That's really interesting. I think a lot of people are going to, have heard these concepts for the first time, particularly locating it within disability models, definitely. And I'm sure people are going to be picking your brains about it. If they haven't already, they will be further. Okay. I'm going to move on to Victoria Petitjean, who's from the Global Interfaith Network in South Africa, and previously Victoria worked across a wide brief of organisations addressing human rights, UNESCO, and also in the LGBT movement as well. And you're going to speak to us today about issues to do with reclaiming the concept of families and traditional values. So over to you. Great.
Thanks very much. Hi, everyone. I think I have a slight imposter syndrome being sitting here this afternoon. I won't be talking about disability rights, but I'll be talking about LGBTQI rights and the work that my organization is doing in terms of reclaiming family rights at the UN. So I work, I'm Franco-British, based out of Paris, and I work for a South African organization, the Global Interfaith Network. And the Global Interfaith Network, the idea was born 7 years ago in 2012 during the conference of the International Lesbian Gay Association, ILGA. And during that conference, historically in the LGBTI movement, the idea of religion has been very excluded from the movement, and people have not wanting to talk about religion because of the harm that religion has been perceived as had on LGBTI people. But in Stockholm in 2012, a group of LGBTI faith leaders spoke about the importance of recognizing the violence and the religious persecution against LGBTI people and the need to address this, but also the need to bring out the stories of LGBTI people of faith. Across the years in 2014, the organization Global Interfaith Network was established and registered 1 year later in 2015 in South Africa. The vision of the organization is a just world in which the dignity, faith, spirituality, and human rights of persons of all sexes, sexual orientations, gender identities, and expressions are honored, supported, and protected. And our objectives are, one, to offer networking, training, resources, structural support, and opportunities to participate in events for members and religious leaders, to create positive change in their home communities where LGBTI well-being and religion are at cross purposes, as well as to promote pro-LGBTI voices of faith, especially in and from the Global South context, in order to impact messaging, policies, and legislation within governmental and regional and international human rights bodies. So as I said, our organization is fairly young. It's 4 years old. We are 4 members of staff. The rest of the team is in Johannesburg, South Africa, and we have 10 board members spread across the world. We have about 350 members, individuals and organizations, all working at the intersection of religion and LGBTI rights. And what I want to focus on today, so we have 3 core projects, but one of the core projects I want to focus on is the one on reclaiming family and traditional values through regional seminar series. And what we have seen over the years in our work, that there has been a call for an inclusive faith-based voice at the UN. And the United Nations, this is a space where religion and LGBTI rights have been separated. And until now, faith-based voices have been extremely conservative on the matter of LGBTI rights, as well as women's rights. And what we have observed through our work is that the very concept of family rights and traditional values are being politicized and are being used to undermine the very system of the UN, as well as LGBTI rights and women's rights. So our attempt has been to develop regional seminars in South Africa, in Southern Africa, and in Southeast Asia, and later this year in Brazil, where we invite activists, theologians, and researchers to talk about what family really looks like at their regional level, as well as to talk about inclusive interpretations of religious texts, and to bring that research back at the UN to counter that very notion that there's only one type of family, that's a mum, a dad, and 2 kids, and to promote the idea that there are diversity models of family. So far, what we have done is we have organized 2 seminars, and we're organizing another one later on in August in Brazil. Out of these seminars, we have published different declarations, as well as different research papers, which we then bring back to our partners who are themselves doing work at the UN and doing advocacy at the UN, so that they can engage when they're facing these conservative voices promoting single definitions of family. They can counter these messages through our research. These are several quotes that have come out of some of these declarations, and this is one particular one. The definition of the natural family as being limited to the nuclear family does not reflect the diversity of family life in contemporary Africa. Family has always evolved and today manifests itself in many forms, such as the nuclear family, single parents, cross-generational, same-sex, childless family, and child-headed family. All of these models of family can and must find their place in the African family and policy-making processes. These diverse forms of extended family into which members are born, married, formally and informally adopted or invited is the true natural African family. And another quote comes from the Ceylon Manifesto, which was drafted after our seminar in Asia, which quotes, "Homosexuality and transidentity are often depicted as imports from the West, attacks on the national sovereignty and culture of states, including in Asia. Yet, if the acronym LGBTIQ is a Western umbrella since the late 1980s, the acceptance of diverse sexual orientations, gender identities, and expressions is present in traditional values around the world, including in Asia, and has been the case for hundreds of years." And now we're in the process of bringing back these declarations, bringing back all these research papers into the UN space. And we're focusing particularly on the Commission on the Status of Women, which happens every year in March in New York, as well as the Human Rights Council sessions, which happen 3 times a year in Geneva. And during these sessions, we are working with our partners who are already doing a lot of groundwork at the UN and have been for many years. And we're doing work with them to carry out side events and invite at these events, invite new voices, different voices, promoting inclusive faith-based messages and deconstructing that conservative definitions of family that we're increasingly hearing in the UN space. We're working with various partners on social media campaigns as well, and our longer-term strategy of advocacy at the UN. And listening to all of you for the past 3 days makes me realize how much there are interconnections between different movements and how much we need to keep working together to counter these conservative voices in the human rights system. And I want to leave you with one last quote, which says, "The single story creates stereotypes, and the problem with stereotypes is not that they're untrue, but that they're incomplete. They make one story become the only story."
Thank Thanks very much, Victoria, for such a young organisation. You've a lot done and with a long road ahead of you as well. And it'll be interesting in maybe some of the questions that people might have as your experiences in the UN and the reactions, to that concept of traditional family and where the opposition comes from now. Okay, I want to finally introduce Shakira Hussain, who joins us from the National Centre for Excellence in Islamic Studies from the University of Melbourne in Australia. And Shakira is a writer and researcher who writes on issues to do with gender and gender-based violence and other issues as well. When I asked Shakira what she was speaking about today, she said whatever the title of the session was respect, support for diverse families and intersectionality. So Shakira, I'll hand over to you. Thank you.
Thanks. It's a hazard of writing too many pieces for newspapers where you don't get to choose the headline. You forget that you actually have to choose a title for things like this. But nobody else is going to just put one on you and then you complain about it afterwards. Sorry. No. Okay. All right. In Australia, it's usual to open these types of presentations with an acknowledgement of the traditional owners of the land on which we speak, or on which we gather. I wouldn't normally do that so very far from home, but given that the topic that I'm going to speak about today is of particular relevance to Indigenous people, I would like to acknowledge that back in the continent that's most usually referred to as Australia, I live on the traditional land of the Wurundjeri people of the Kulin Nation, and I pay my respects to them, very long distance, to their elders past, present and emerging. And I would also like to provide a content warning. I'll be quoting historic material that contains offensive racial and ableist terminology. So as already covered, I want to take an intersectional approach to the topic of the summer school. For many of us, the constraints imposed upon our rights to family life arise from a confluence of factors relating to our gender, racial and ethno-religious identities, as well as our disabilities. So I'm going to start by providing a very broad background in an Australian context, but it's similar issues arising in North America and Europe as well. And then I will talk specifically about the research that I've done involving Muslim communities in Australia and how disability has factored in that research. Okay. So feminism in general and reproductive rights in particular are currently under attack in the United States and elsewhere in the developed world in a way that few had foreseen only a few years ago. I therefore feel I should state very clearly that I am calling here for feminist self-reflection, not for some kind of Handmaid's Tale style shutdown of feminism itself. Feminist campaigns for reproductive rights have mostly centered around the right of the access to safe contraception and abortion. But women from marginalised communities, marginalised in various forms, have historically been denied the right to establish families, as of course has been discussed here over the past few days, and the right to raise those offsprings that they do produce. The removal from fair-skinned Indigenous children from their families and communities in Australia in order to breed out the black, quote unquote, it was the rationale behind Australia's notorious stolen generation. And Aboriginal children continue to be removed from their families and communities at an unacceptably high rate. The pill was not developed in order to allow middle-class white women to discover the joys of recreational sex, but as an attempt to limit the number of black and brown babies brought into the world. But white bodies too had to be disciplined into the service of racial supremacy. And again, I realise that previous papers have already touched on this connection of eugenics and feminism and disability. Historically speaking, feminism, family planning as it was then called, and disability care all had a very long association with eugenics. My colleague Jane Carey from Australia has written a paper about this topic, which takes its title from a 1935 motion from the Mothers Club of Victoria, that's the state of Victoria in Australia, in favour of voluntary sterilisation for the physically and mentally unfit. And as the supporters of this resolution stated, Australia should be populated by not just by the white race, but the best of the white race. And you can see this also in the case of the Australian psychologist and educator Lorna Hodgkinson. In 1924, Hodgkinson founded the Sunshine Institute as a private residential school for the education of so-called mentally defective children. Now rebranded as Unison, and I have no idea if I'm pronouncing that correctly. The organisation founded by Hodgkinson has shifted from residential care to community support, more or less in line with conventional contemporary thinking. But its website still carries a tribute to Hodgkinson as a remarkable Australian of great dedication and vision. However, in founding the Sunshine Institute, Hodgkinson was following the lead of her mentor, Walter Fernand. Hodgkinson was also one of the very first women to get a PhD from Harvard in education. And her supervisor and mentor was Walter Fernand, the superintendent of the Massachusetts School for the Feeble-Minded. According to Fernand, the only way to reduce the numbers of the feeble-minded is to prevent their birth. And he also said, high-grade female imbeciles are the most dangerous. They are certain to become sexual offenders and spread venereal disease or to give birth to degenerate children. And Hodgkinson brought that same kind of thinking to the benign and happy-sounding Sunshine Institute. She said, mental defectives are breeding freely and bringing all the evils which are associated with mental degeneracy, such as crime, pauperism, and venereal disease. The problem, she argued, demanded permanent care and control in properly established working colonies. She addressed the 1929, she propagated these views in forums such as the 1929 Australian Racial Hygiene Congress, as well as the Women's Reform League. Segregation in institutions like the Sunshine Home may seem like a more humane option than the forced sterilisation practiced elsewhere, but I doubt that the Sunshine Institute was free of forced sterilisation, let alone the extermination of disabled people in Nazi Germany, according to really the same rationale. But this segregation is an abusive practice undertaken for the supposed protection of the able-bodied population rather than to serve the interests of disabled people themselves. But these practices continue to the present day, albeit in a softer form and without the overt eugenics rationale. The 2013, much more up to date, more recent. The 2013 Australian Senate inquiry into the forced and coerced sterilisation of people with disabilities in Australia found that it was continued, that numbers were not possible to discern. Sometimes they were continued with consent of the courts in various, and that's a state-based practice. But the reasons it's impossible to establish the name is that there's also allegations of people being sterilised using switched Medicare cards, which is the healthcare card in Australia, or taken abroad for sterilisation there. And so the federal government welcomed the report and said that they would act on its recommendation to address this practice, but their form of addressing this practice was just to say to the various states, you guys should really do something about this. And there has been no substantial action. Yeah. And you can see still this kind of linkage of care with control in the rationale when people are seeking court orders to, and parents in particular seeking court orders to allow their disabled daughters in particular to be sterilised. There seems to be much less concern about the fertility of disabled men. It is to reduce the burden of care, because of period control, and also the fear of pregnancy and childbirth. and parents say that it's just unreasonable to put them to the expense of having to go to the family court. It should be parents of the disabled children. It should be their parents, the parental decision. But getting now to my own research on the Muslim population, and I have not taken research into disability in this factor as it's still at a very early stage. So Muslims in Australia are frequently accused of both overbreeding and inbreeding. And overbreeding by Muslims, not just in Australia, actually in Europe in particular, is said to pose a demographic threat to the non-Muslim population. We're going to bring about this whole Sharia law, jihad thing just by having more babies. It's, as I said in my research specifically about Muslim women, wombs are just as dangerous as bombs, it turns out. But then when you combine that with the allegations of inbreeding, of Muslims intermarrying and therefore producing higher rates of disability and overburdening the health systems of the countries to which they've migrated, you see this confluence of like racism, misogyny, because it's bodies, it's sex, it's women's bodies that are producing it, and ableism. I will say, there are high rates of endogamous marriage in not just Muslim communities, but also some other migrant communities, and that does bring about risks of high rates of recessive genes. And I can speak to that in my own thalassemia, which is very common in the Punjabi community in particular, and on my father's side of the family. So I will not pretend that that's that is a complete tabloid myth, but it lends itself to some very sensationalist tabloid headlines, and there are all types of risks in generating families, like having a baby over a certain age, or you don't really need me to run through them. Why it is that it is particular marital patterns among particular communities that are seen as abhorrent and somehow freakish is we need to consider. So this is often expressed in these very aggressive, and explicitly racist terms, but also in quite liberal feminist terms. So that this then also aligns with another issue that attracts very sensationalist headlines and has come, rightfully under legislative focus in the past number of years in Australia, the United Kingdom and elsewhere, and that's the issue of forced marriage. Now, I would say that that is not a terminology that I'm comfortable with, but explaining that would take more time than we have available. It's the term that's in most common usage. I will just say that, I add lots of footnotes to that, lots of footnotes and lots of caveats. Okay, and then, and the issue of disability and forced marriage is in need of much further research. In Australia in particular, there is not much. In the UK, there's been more, but not enough. Okay, but one of the more major papers on this issue in the United Kingdom, a 2015 paper by Rachel Clausen and Rachel Eisen on forced marriage of adults with learning disabilities, found that it was a practice that involved men and women as victims in just about equal numbers, which is, with forced marriage as a whole, it's mostly women, but not only. LGBT men also are vulnerable to it. Okay, one thing about forced marriage in general, it's a practice that parents often undertake in the belief that, well, actually, I don't think very many of them think that they're forcing their children into the marriage at the time. They think that they are just arranging their marriage and the kids being kind of stubborn and not seeing it's all in their best interests. So they have to argue the case very, loudly, and and sometimes, things get out of hand. Anyhow, and in the case of offspring with disabilities, their motive is generally to provide them with a caregiver. Now, if we think back, some of the forums that I've attended around forced marriage, the issue of able-bodied women who've been coerced into marriage with disabled men, and sometimes it wasn't, well, coerced by deception, as in they agreed to the marriage, they didn't know about the disability until afterwards, so it wasn't informed consent. And the kind of ableist language, of this able-bodied woman, who is being handed over to a disabled man, the language around the disabled man, and the language around the children that the woman fears might result. It's not good. And it's in forums where you would have hoped there would be a less problematic attitude to disability, and there would be, I think, in other circumstances, in other contexts, but in this context where they're talking about, and this is usually women from outside the community talking about, rescuing women from another community, and it doesn't get translated well, and and it's also some interesting findings about in what circumstances consent can be, because there's one court case in the United Kingdom which every time I want to turn it to it, it takes me forever to dig it out of the files, and I wasn't able to do it for today's paper, so I'm relying on memory. But anyhow, was a court case in the UK where of a disabled man who was in residential care and an able-bodied woman who'd been brought from India for the marriage, and and visas are often a factor here. The able-bodied partner has been brought from overseas, and the care home had reported it, so there was a court order which forbade her to continue to visit it, but he was immensely distressed. He did understand that she was his wife, or at least that she was somebody who was in a relationship of some sort with him. When she was no longer there, he, as I said, became enormously distressed. And she also wanted to continue the marriage. This wasn't stated in the findings, but the marriage provided her with grounding with a base in the United Kingdom. She would probably have been forced, if you're enter the country on a forced marriage, there is visas that you can have that allow you to stay if you leave the marriage. But she wouldn't have had, presumably, and this again wasn't stated, presumably she was living with his family if she'd exited the marriage. So yeah, she did not want to leave the marriage either. So the court finding on this case said that she could remain in the marriage, that the marriage could continue, the marriage would not dissolve, but it must not be consummated, and if it ever was, she would be charged with rape. It was found that he was capable of consenting to the marriage, but he was not capable of consenting to sex. And it's this, and okay. And so then if we turn towards attitudes within the Muslim community itself, of course it's a community that has the same or similar, or sometimes even heightened, often even heightened, ableist attitudes to the mainstream community, which may mean that parents basically want to, don't want their children to have a sexual life, let alone to have more children. And also we'll see acknowledging their child's disability. And again, I'm not going to say that this is an attitude that's unknown in the mainstream community, because it will reduce the marital chances of their other offspring. So while on the one hand you have some families that may be marrying off children without their full consent, you have others who are not allowing their children to enter sexual relationships at all. There's a hadith in Islam that says that marriage is half the religion, but not for everybody, but again, it's in order to allow non-disabled children to fulfill that, to have their marriages and where marriage is often arranged and according to quite reductive concepts of what makes a desirable spouse. Having a disabled sibling will make it much harder for the rest of the family to get married, so you therefore keep that sibling out of sight and don't acknowledge their existence, or even not necessarily locked up, but you don't take them out to community events and try to, keep them back. So it isn't just that you might be not allowing your disabled child to have, intimate relationships, but you will, for fear of your other children not being able to have intimate relationships as a result, you will not allow them to have full and public and social life. Okay, and that's it for me.
Thanks very much, Shakira. That's the start of a very long conversation. I think one that could continue for quite some time, bringing in lots of different issues around consent, capacity, culture, all of those things, and also I think the dearth of research in the area as well is something that maybe researchers here can consider, and those around the world. I'm going to open up to the floor. The roving mics are ready. Yes? Okay. Have we got questions?